So question 11, when do you do a peripheral iridotomy? Never, preoperative, intraoperative, postoperative.
Yes, this is a great point. So I always do a peripheral iridotomy, and I do it intraoperatively, and I use a retinal scissors to make a 6 o'clock incision, and then I'll usually put the inverted Sinski in under the iris to just make sure that I've got a nice, that I have patency there. I think that.
So how do you actually do it with the retinal scissors?
So I take the retinal scissors, 23 gauge, through a side port incision, and whichever one gives sort of the best approach towards 6 o'clock. And the scissors are curved, so I will basically, as you indicate, these disposable instruments can be bent. So I will bend it. I will face the curve of the scissors downward towards the iris, and then I'll sort of that's sort of the direction in which I'll be cutting, and then I bend the shaft of the scissors upward so that I have a nice, so it's a convenient, comfortable hold in your hand. And so I'll place that through the side port incision, again, kind of reaching across the anterior chamber, curve the scissors downward, and then with the scissors open, I will use one of the blades of the scissors to engage the iris. And I usually put a little bit of sort of radial traction, so I might move the scissors out to maybe a clock hour. One can certainly produce an iridodialysis here, so you don't want to be too aggressive with this traction. But the traction is important because it allows the tissue to sort of get in between the blades, and then you just basically cut. And that usually is enough, maybe one or two of those. What can often happen is if there's a thick iris, you'll get into stroma, so you can just kind of repeat the exact same action, but then have the scissor, instead of on the iris surface, it would be sort of in the iris stroma, and then you can kind of once you get your small hole, you can actually sort of do a blunt dissection with the scissors into the hole and then open up slightly. So that's pretty much it. It's a one-handed technique, and it works very well. Okay, occasionally you have to kind of work at it for a bit if a patient has a very thick iris, but I figure it's probably more convenient that way. We are there. We're in the eye already, as opposed to doing it preoperatively in the clinic with a laser, that sort of thing. The one thing I would say is that rarely you can get bleeding, and that that can be anywhere from not a big deal to a big deal. So I would say that is something that people do need to be aware of. I think that certainly happens less than cases where the patients get a pupillary block, even with a decent dilation with cycloplegia.
If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.